Thanks, Glenn, for being with us. Actually, we've been working in the WFH for this challenging task to update the guidelines of the hemophilia to the third edition, and Glenn in particular put a heavy load to achieve this in an outstandingly short time, and to come with a very important improvement into the guidelines compared to the second version. So as a history, the guidelines for management of hemophilia, the first edition was published in 2005. 6 members were the writing group. There were no references and bibliography of 10 documents only. And then the second edition came in 2012 with 11 members writing group with extensive literature search and grading of cited levels of evidence on which recommendations were based. And this second edition was published in Hemophilia and was endorsed by the International Society on Thrombosis and Hemostasis, and the first hemophilia guidelines to be hosted on National Guidelines Clearinghouse website in the USA, with more than 1,000 citations and more than 1 million downloads in 6 languages. So it was really an important document. So what were the difference between the first edition and the second edition? In the first edition, there was the general management, comprehensive care, the laboratory diagnosis, the musculoskeletal complications, clotting factor concentrates, and treatment of bleeds. Then in the second one, there was more. Special management issues was added to this edition, as well as treatment of specific hemorrhages. So what happened during 2012 when the second edition was published into 2020 when this third edition? There was increased use of genetic analysis technologies to play a greater role in the management of patients and their families. And the advent of newer clotting factor concentrates with extended half-life has not only led to decreased burden of care for patients, but more importantly, extended half-life clotting factor concentrates have made it possible to maintain significantly higher factor trough levels on regular replacement therapy than has been possible with the standard half-life. So it reduced the burden of care and in the meantime improved the trough levels, which consequently reduced the number of breakthrough bleeds and quality of life. So the sections that were added in the third edition were the principles of care, what is ideal and how should we get there. The genetic diagnosis from research to clinical care. The prophylaxis, where the new guidelines emphasize that the prophylaxis is the only way to treat hemophilia. So raising the bar of care. Management of inhibitors by defining in detail both ITI and management of bleeding, and adding the outcome assessment to recognize core significance in assessing treatment. Section that was removed is the transfusion transmitted infection, because it can be dealt now with other experts. And all chapters revised and updated with current literature to about 337 recommendations. So a very, very comprehensive. And this was published in Hemophilia, I think, in July this year. And we are very proud that we have from our region, Emna Guider from Tunisia contributed into these guidelines, and also Abdelaziz Sharif on the patient side from Jordan. So what was the modifications in the methodology to produce this guideline compared to the other guidelines? It was the appointment of independent process and methods expert to work with the content lead, inclusion of well-informed patients, and for the first time we include patients, like 25% of the panels that voted in the Delphi processes were patients. Comprehensive and systematic review of literature for each chapter with creation of evidence tables for review by the panel for making recommendations, modified Delphi method for consensus-based recommendations. And this is very important because in sometimes the level of evidence was not that strong. So, I mean, the Delphi process could help us to produce the recommendations, and extensive internal and external review of final draft with suitable modifications. And for this also, the WFH dedicated a practice or a guideline process task force in order to enforce and move forward in a very pragmatic way to have these guidelines produced on time. So the third edition is guidance for all. It is applicable to all circumstances, both less and more resource environments. So we took care of these differences between the different levels of practice according to the economic capacity of the countries and the level of development. Explains principles and practice of hemophilia care to non-specialized physicians. Some limitations of the second edition addressed particularly chapters on prophylaxis, management of inhibitors, and outcome assessment. Description of new therapeutic products and changed paradigm of treatment. Most critically, higher trough levels of more than 1% are now a reality. Application of genetic methods to diagnosis and prognosis, and defining the principles of care for consolidating the present and seeking beyond. So here we emphasize that regular replacement therapy or prophylaxis is the only way to alter the natural history of the bleeding in hemophilia. So for the principles of the care, in the first chapter, it describes how can we, especially in large countries like Egypt, how can we nationally coordinate the delivery of care, and how we organize the access to safe clotting factor concentrates and other hemostatic products and curative therapies, like the gene therapy, for example. And how to advance the laboratory diagnosis and also to include the genetic diagnosis in the routine practice. This is a step that we need to improve in our country. The education and training for hemophilia, and the principles of the multidisciplinary care, the regular replacement therapy or the prophylaxis, the management of inhibitors, management of musculoskeletal complications, management of specific conditions, and outcome assessment. Outcome assessment will become an important part embedded in the care, because these are expensive therapies, and we need to prove to the payer that with our practice or using of these expensive therapies, that the outcome is cost effective and economic. So I will highlight some points for that you probably read. It divides the hemophilia care centers into comprehensive care centers and only hemophilia treatment centers, and it assigns the tasks for each of these two types of centers. I will not go into the details in the interest of time, but they more or less share the same responsibilities, except for some more advanced points that has to be taken care by the comprehensive care center. It describes also the sites of bleeding, where it says that joints are the most affected sites for bleeding, followed by muscles and then others. The management of pain is very important, because still we have severe hemorrhage that affects the induces pain, or those who have chronic arthropathy, they have chronic pain. So the different protocols for the management of pain is well illustrated in this new section. And it also describes the different treatment products, whether they are the clotting factor concentrates, the non-replacement therapy, and also recognize the limitations in some countries that these therapies are not available, or the access to it is limited, and that in sometimes the use of other blood components, and they advise if this is mandatory, then using virally inactivated products is better. It describes the different levels of replacement therapy according to the resources in the country. So there are two levels, level where the resources are unlimited and or the resources are limited. And this is shown in the guideline. It also describes the different types of the prophylaxis, whether the primary prophylaxis that starts before any joint affection or the secondary prophylaxis with more than 2 or 3 bleeds and later than 3 years old, but still the joints are not affected, or the tertiary prophylaxis when the arthropathy starts. And for the first time, we have the description of what's called low-dose prophylaxis. So in the previous edition, there was an identification of a high-dose and low-dose, intermediate dose prophylaxis, comparing the Swedish protocol to other protocols from Netherlands, from Canada, and from France. But for the first time, due to the availability of the humanitarian aid and also the availability of concentrates in many developing countries, there were several studies on low-dose prophylaxis and its efficacy, and which shows that it can be equivalent to the on-demand therapy regarding the consumption of the concentrates, but in the meantime, it's much more efficient in reducing the morbidity of the patients with hemophilia. Also, it documents the benefits of the extended half-life clotting factor concentrates, whether due to the less burden of the disease due to less frequent infusions, or in the meantime to the higher trough level, which can improve the quality of life. It also identifies the acknowledgement of the non-factor replacement, which can be used as a bypassing agent in case of hemophilia A, referring to the emicizumab, or even it can be used for patients with hemophilia with non-factor, with non-inhibitor patients, and that it proves that it is very efficient for reducing the burden in the inhibitor patients, and more effective than the other bypassing agents, and as well it's very effective in treating patients with non-inhibitor patients, because the level of its activity is comparable to about 15% factor VIII activity, which makes this much more efficient compared to the other prophylaxis protocols. It also describes the management of inhibitors, whether on when are the times indicated to test inhibitors at different circumstances, what are the potential risk factors of the inhibitors, and how to treat inhibitors, whether the low titer inhibitor or the high titer inhibitor, and when to introduce immune tolerance induction. And I believe that this is a point also that we have to look at for the young kids in the early stages of the development of inhibitors. Kids like 2 to 3 years, if we put them on the low dose immune tolerance, it can be very cost effective compared to the cost of the bypassing agents. So my final slide is how to use the guidelines. These guidelines are primarily intended to help clinicians make decisions about diagnostic and treatment alternatives. Other purposes are to inform policy, education, and advocacy, as well as stating future research needs. They may also be used by patients to help them make informed decisions, and this should be the role of the Egyptian Society of Hemophilia, is to educate the patients on what's new in these guidelines and how they can use it to advocate for their rights, and also to make decisions for the type or the program that they will follow in their treatment. The guidelines are not intended to serve as a standard of care. The clinicians must make decisions on the basis of clinical presentation of each individual patient, ideally through a shared process that considers the patient's values and preferences with respect to the anticipated outcomes of the chosen option. And decisions may be constrained by the realities of a specific clinical setting and local resources, including but not limited to institutional policies, time limitations, or availability of treatment. So we have to study these guidelines. We have to try to adapt it to our local circumstances for the best management and best outcome in our bleeding disorders community. And with this, I thank you very much.